Great. Do I pull it up here or just go off the screen?
Yeah, our one thing is broken. So
Sure.
it's just up here.
Okay, perfect.
Oh, I have. Sorry for not pulling this up for you.
Oh, it's fine. I figured it was. That's right. Awesome. Thank you.
Okay, everyone, welcome. I want to welcome Dr. Eden Lake, who's one of our dermatology attendees. She's going to be teaching you guys about dermatologic emergencies.
Hi, team. So nice to see everyone. We have better turnout than last time I did this, so that's exciting. I like the in-person nature. I feel like that's good. I love interactions, so like please stop. This is very informal and casual. I think that's the only way we learn anything. So if you have a question or need me to expand on something, please stop me. Otherwise, yeah, it says for the intern, but it's for everybody. Even derm residents need this. So I unfortunately don't get paid by anyone to do anything fun. A lot of the photos are my own, and almost all of them are from inpatient consults from Loyola. I did that intentionally to make it very relevant. These are not obscure things. These are things that you have seen here definitely and will see. A few others just for demonstration are from one of our big textbooks. And then every single treatment in all of dermatology is off-label. There's probably like one FDA approved medication for like one of the things we're going to talk about. So everything's off-label, and that's just the world that I live in. So FYI. We're going to talk about a few different things today. I'm sure you're familiar with some of these. The abbreviations SJS-TEN, that's for the really bad, your skin falls off drug reactions, right? So Stevens-Johnson and toxic epidermal necrolysis. DRESS is drug reaction with eosinophilia and systemic symptoms. And then it's also called drug-induced hypersensitivity syndrome. So whatever you prefer, they're the same thing. AGEP is acute generalized exanthematous pustulosis, where you literally get tiny little pustules all over your body. Eczema herpeticum is herpes gone bad. And then pyoderma gangrenosum is that wound that will not heal and often is expanding and is scary. So I want to talk briefly just about when you call a consult. When you call us and you say, I have a patient, they have a rash, that is equivalent to calling cardiology and saying, my patient has a heart thing. You would never do that. You would be chewed out. It would not go well for you, right? Like you're going to know what the EKG showed. You're going to know what those heart sounds, you're going to do a physical exam. I've had residents call and they haven't seen the patient. That's not okay, right? Like you got to communicate to us what's going on, just like any other specialty you would. We are also kind of a medicine specialty. We do an intern year. I've done that intern year. I feel you. Yours is a little harder than mine was, so sorry. But we have to use the same words. The reason that matters is that one, sometimes just what you tell me over the phone, like 911, you need to do something immediately. Sometimes it tells me how quickly I need to see the patient, and sometimes it tells me what I need to bring to the consult. So there are certain things that are very specialized that we have to grab from clinic, complicated stuff like that. So the more information you give us, the quicker we're going to get to a diagnosis and help the patient. So tell us what you see. We'll talk about this later, but like a maculopapular rash. Does anyone know what that means? Like, what are you saying when you say that? You're telling me that their rash has flat spots and bumpy spots. It's not the most helpful thing, right? So we're going to talk about other, I know what you're trying to say when you say that and the better way of saying that. But just learning the words that we use, it's just like learning how to tell a cardiologist about a heart sound. It's the same thing. It helps us be better doctors and communicate better. So is there mucosal involvement? That's a really, really important thing. Please examine that, especially if you're in the emergency department and you think that this is Stevens-Johnson's or TEN. Literally the number one thing I care about is mucosal involvement, and you have to kind of do that. So don't forget that mucosa is skin too. Okay, so erythema multiforme for the most part is kind of a no big deal thing. See it all the time. The common presentation will be somebody who has a history of cold sores and they just have this kind of targetoid rash on their hands and feet. However, there is erythema multiforme major, which is basically EM gone crazy. There is a really intense debate whether EM and SJS and TEN are on a spectrum. I was trained in the class of they are not, and that EM is a separate entity, it has totally different causes, this is a different progression, it has a different prognosis. So I generally do not think that EM is going to morph into those other things. There are some people, some dermatologists, good dermatologists, I don't think anyone's wrong, I think we don't have all the information, that do feel that these things can morph into one another. In general, like more of the targetoid lesions, palm, sole involvement is actually a good thing for the patient. So even if you're seeing a ton of mucosal involvement, it can still be EM and it can still be not as scary for the patient. Usually it is HSV or mycoplasma is the culprit, but I've seen it to nothing. I've seen it to something. The fun thing everyone likes to do is, oh, we need to treat them with Valtrex. And I'm like number one of number one proponent of just give valacyclovir because it hardly does anything wrong and it saves the day a lot of times. In this case, it doesn't actually change the course for the patient, even if you absolutely know that it was induced by a herpetic outbreak or triggered by a herpetic outbreak. The reason you would do a valacyclovir is because you know their skin is broken down. If they have an active herpes infection, you want to make sure they're not going to get like a herpetic outbreak that's exacerbating their current EM, if that makes sense. So you don't do the valacyclovir to improve the patient's EM prognosis, you do it for any active herpes outbreak. But it can look really bad. We had a 19-year-old who had recurrent EM, very unfortunate, and he was intubated and trached for, I think, 2 weeks. It was pretty bad, and it was just this. So it definitely has a dark side, but the vast majority of cases will be outpatient. They'll come in, they'll have little targets on their hands, and just remember to ask about cold sores and genital herpes outbreaks because it's almost always like 90% of the time linked to that. So just another picture of the target. So it's just kind of cool that our skin can do this. I don't know, that like make these perfect little circles. I just think it's amazing. Clearly I like skin. So here's an example of mucosal involvement. So from this picture alone, I have no idea what this patient has. So this can be EM, this can be SJS, this can be TEN. These are syndromes that I need a lot more information to give them a diagnosis. Even pemphigus can look like this. Honestly, people have had their mouths open for a very long time from intubation that can look like this. So this picture alone, I can't tell you exactly, but this does happen to be a case of EM. So Stevens-Johnson is this scary now. We're very scared. Really for you guys, the answer is like burn unit. So, right, not that stressful. In Stevens-Johnson, there is a Nikolsky sign. Has anyone seen a Nikolsky sign? Okay, so it's a real thing and it's very disturbing when you actually see one. But please, if you ever have a drug rash patient or you're not sure, do it, because if you see it, you'll never forget it and it will like shape. I hope you'll think it's as cool as I think it is. But basically you put pressure, and we're not talking like really, really hard or anything, but decent pressure where you are next to like a little, if there's a blister or something, a bulla, you're going to go just adjacent to it. And can you actually slough their skin off like this is showing? So this is a very aggressive Nikolsky sign. You usually don't get that much from it, but you can actually shift the skin and peel it off. And that's because all those top skin cells are dead and you can literally just wipe them off the surface. So cool. So the time course on this one is 7 to 21 days after a suspected medication. I've also seen SJS to nothing. I've seen SJS to the flu. I've seen SJS to vaccines. I don't know. So sometimes it's like, did they take ibuprofen and they just don't remember? Probably. I think ibuprofen causes everything because everyone's like, I didn't take anything. I'm like, well, you probably took a Advil and you just aren't telling me. But that's just being cynical probably. So sulfas, anti-epileptics are the most common, allopurinol, NSAIDs, lamotrigine. That being said, it can literally happen to anything. Then a Nikolsky sign is key, as well as the mucosal involvement. And the main thing is stopping the agent that we think it is. There is no test that can be done on a patient that tells you what med did this. I will never be able to tell you what did it. I can tell you what's more likely. So a lot of times it's, hey, what should I stop? And I'm like, I really don't know, but these are the most likely. And it's really tough, but just know that there's absolutely no, a skin biopsy isn't going to show you that. There's nothing I can do. Can patch test, whatever, SJS patch testing doesn't really works. AJET, maybe it works. There's nothing in that moment that I can really do to 100% tell you what is potentially going to save this patient's life. And I think that's what's really hard about this disease. Yeah. So TEN, so SJS is when you have like 10% of body surface involvement. Once you get to 30% or more, then you're in the TEN category, but they're the same disease. So these are a spectrum. Definitely nobody disagrees on that, where SJS is sort of the minimal form. And you can have really minimal SJS, where Bactrim is probably, if you ever see dermatology, we never prescribe Bactrim because everyone who has SJS in my life has been on Bactrim. So I'm just terrified of it. But it's the same meds, it's the same story, it's the same everything. I'm doing a support group for SJS TEN survivors. Our ophtho group is really involved in that, and we have support groups that are really great. And they had never had a dermatologist speak at a support group. It's usually for the ocular findings because you get horrible scarring. I mean, the long-term consequences of these diseases is very severe. Smokers, especially smokers, have horrible bronchial disease afterwards as well, just from all of, that's mucosa too. All of these areas get scarred, it's terrible. Patients can have fertility issues because of vaginal scarring, things like that. Just it's unbelievable. You can lose all your fingernails, cool stuff. And they had never had a dermatologist speak at one of these support groups. And for like 40 minutes, they were just like, so wait, this is from that too? And they just didn't know. And it's amazing what this can do. So usually in the wake of SJS or TEN, there's not much scarring. It's a very superficial epidermal process. The epidermis is that top part, right? Remember path, right? The dermis is the part underneath. And once you get into dermis, that's when you have scarring. So most of the scarring we see is because debridement was done a bit too aggressively. It's one of the reasons I prefer to not ever debride these patients, just a training and personal preference. And then also if you just have a really horrible inflammatory case or a super infection. So the biggest problem with this is that you're losing they're basically a burn patient, right? You're losing your ability to maintain fluid, but also you're open to a massive, like you're just an infection waiting to happen. So if there's a bad infection, especially cutaneously, then we can see a lot of scarring. Usually people are okay. They kind of have like baby skin afterwards. And then skin of color, you're going to have repigmentation around the hair follicles. It's called perifollicular repigmentation. If you've ever seen that, it's the coolest thing. But that's where all of the little stem cells of your pigment come from, is from around the hair follicles. So areas that have hair are going to repigment a lot quicker. And it's just such a cool thing. Can you tell I really like skin? Really like skin. Any questions so far? Yeah. So the question was, is there an amount of body surface area involved that should or should not require burn unit? I will defer to the burn unit team. I think it depends on number of beds available. You can also be on like the burn floor and get burn care without being in the burn unit. I think that the burn team should be aware of a patient, even if they have minimal disease, so that that nursing care can be done and so that a transfer can be quick to the unit if necessary. If somebody's coming in and they've had SJS affecting 2% of the body surface area and it's been 3 days, it's not likely to progress. When I'm worried about it is they're coming in, their skin is really, really painful. It just started, they're starting to slough. I don't know where that's going to go. Them, I would just go to the burn unit because I just don't know what's going to happen. If it's been a few days, it's less likely to progress really rapidly. Not definitely, but you know. Okay, so dress is probably the only thing that still kind of makes me nervous. SJS, like it's so funny. The longer out you are from your training, the less scared you get of things, but dress still really creeps me out. So basically, dress is your entire body has just reacted horribly to a drug. Dress is almost always a drug, and it's weird because it's like a much more delayed onset. So it's 15 to 40 days after the drug. And it's really hard because that is a hard question for a lot of our patients is what did you take 3 to 4 weeks ago? Right, it's hard. So that's definitely the hardest part of it for me because, oh, well, I was on this for a little bit, then I stopped it. Okay, well, that really shouldn't have done that. It's a scary disease that can involve just so much of the body. It's a syndrome. I think I listed organs. Yeah. So there's lymphadenopathy, there's EOs, there's fever, there's liver, kidney, cardiac involvement. I've seen an acute myocarditis from DRESS syndrome, and they did a cardiac biopsy, and it was literally just EOs, just flooded into the organ. I mean, it's the craziest thing. Thyroid disease is a late onset finding. You can actually completely squash someone's thyroid with DRESS syndrome. So just scary things. Almost always it's an anti-epileptic drug, like especially the bad cases I've seen. And then other agents, sulfas, allopurinol. So scary. So every time you give a drug, be afraid. No, I'm just kidding.
Is it usually a dose dependent thing, or is it a new med, or is it a...
So the question was, is it dose dependent or new med? I would say all of the above. It's new med is definitely more likely. However, I have patients who had ibuprofen a million times before. All of a sudden it gave them SJS. I also had a patient who was on an anti-epileptic and it was a dose increase, definitely SJS, absolutely no other triggers. So I'm convinced it can be anything. It's all on the table, unfortunately. Okay, so this is the better word for that maculopapular rash that you want to talk to me about. Does anyone know what morbilliform means? So it's measles-like. So this is saying, hey, it looks like a measles rash, which we don't see that anymore. But my gosh, it is so helpful and descriptive. I know exactly what you're saying if they have a morbilliform rash. I would say the most common consult we get is when people, or when it's internal medicine saying, I have a guy and basically they want to know what this is. Is it due to a drug? Is it due to a virus? Is it DRESS? So DRESS, I can tell you by doing an exam, what are the drugs involved? Is there a drug that seems likely? And then you have to follow labs. So if you see that, if you take nothing out, well, there's 3 things I want you to take from this lecture. Number 1, if you see this rash, you need a DIF and LFTs, period. Because I can't tell you if this is DRESS without that information. So it's a syndrome. There's diagnostic criteria. I need that. So get that on board right away. That's the smart thing to do, okay? Because I cannot look at this. There's no biopsy. Nothing else is going to tell me what this is. So a biopsy for a morbilliform eruption due to a virus, a drug, or DRESS are identical on path. So when you asked us to come do a biopsy, I'm going to be like, but why? Because I know what it is. I can't tell you necessarily what caused it, but that's where the history and us investigating is going to come in. The biopsy itself is going to show a morbilliform eruption. The etiology is the same under the microscope. So just keep that in mind. So I often don't biopsy these because it's not going to tell me any additional information other than what we already know. Treatment, usually topicals. If there's no signs of DRESS or anything else worrisome, you can look up for, it depends on how severe it is and how uncomfortable the patient is, how aggressively we look into the etiology. If we're really concerned for a drug, we try to figure out what drug it would be. It's usually more in the SJS timeline of like 1 to 2 weeks. And I think 4 days is very early for that, but that's what it says. And in adults is almost always drugs, but in children, it's almost always viral. Okay, AGEPA is one of my favorites. So it's just so like classic. It's like, I was trying to think of an equivalent for you guys, but like, you know what it is, like the second you walk in the room and you like save the day, it's one of those. So this one's really quick. So the patient had a drug like 1 to 4 days prior, except for hydroxychloroquine. And that is the beast that kept me up at night. And that's on the next slide. But you get teeny tiny microscopic little pustules. Now, morbilliform drug eruptions related to DRESS can have pustules too. The nuance or like the little detail that's the difference between them is AGEP pustules are non-follicular. It's really random. You don't really have to remember that. Just kind of a cool thing that these don't go in a hair follicle, whereas pustules and DRESS do, right? So weird. It's just kind of cool. It's a very superficial process. On path, it's literally just the very, very top of the epidermis has like little tiny pustules. And the coolest part is if you biopsy this before the pustules come up, you can see the pustules on path. Isn't that just the coolest thing? I know, it's so cool. You can also have systemic features with this too. So fever, leukocytosis. I've had patients with lymphadenopathy as well. So there is kind of an overlap between AGEP and DRESS as far as the systemic symptoms go, but they're caused, usually the drugs are different, time course is different, and severity is very different. But a leukocytosis with AGEP is completely normal and really expected. Yes, you can have targetoid lesions, you can have other weird things. And for DRESS, facial edema, a little bit for AGEP too, but really DRESS, faces get really, really swollen. So sometimes that can be a good clue too. Okay, so just the drugs, so different drugs, right? So this is very different. Well, I mean, anti-epileptics get on everything, but different than the classes that we were looking for SJS and TEN. So just keep that in mind. So this is going to be like even Tylenol, tetracyclines, sulfas, terbinafine. That's kind of a weird one, but it's more likely to cause AGEP than any of the other ones, calcium channel blockers, and hydroxychloroquine. So this is AGEP due to hydroxychloroquine. This stumped me. I had, there are like 5 case reports of it and how it's just a totally different beast, but it's a delayed onset. So this was 3 weeks after she started the medication, which is why it wasn't super forward in my mind that this could be AGEP. And so on biopsy, there are several different things that can have those tiny little pustules at the top. So we were like, oh, maybe it's this other thing. Anyways, Plaquenil or hydroxychloroquine has a super long half-life. So it takes forever to go away. This patient had stopped the medication a week prior and it came up after she'd been off it for a week. Isn't that, it's wild. It's so wild. She's fine now, in case you're wondering, but it was a mess when going through it. So drug rash is done. Everyone okay? Okay, great. Eczema herpeticum is basically eczema that is, or herpes that is taking over vulnerable skin. It's kind of a general term we use for that, but you can have any reason for skin breakdown and have this happen. Eczema is the most common thing because eczema is the most common. It can be in a drug reaction patient. I have some photos of that. It can also be in really rare skin disorders. And this almost always needs systemic therapy. If it's like a tiny little bit, fine not, but I almost always IV treatment, especially in kids, not really your issue, but it's an important thing to do. So this is HSV in a Haley patient. Haley is a pretty rare genetic disorder where your skin just kind of breaks down in certain areas. And in itself, it's usually not that bad. Her disease in general is pretty mild. And then you can see these little tiny circles coming up here, and it literally spread all over her entire body after that. So this is a patient knowing her skin breakdown. She also had a drug rash going on at the same time that we were like, IV, like give IV right now. Don't wait for the PCR. I don't care about any of it. Just give it to her because the benefit of starting that early outweighs the risk of whatever the acyclovir is going to do to her kidneys. And she was on dialysis anyway. So. Disseminated zoster is also a pretty tricky beast. This was a case for here. So both of these are here. This woman had untreated CLL because she didn't want chemo. I'm not really, her white count was like 123. It was disturbing. Very smart woman too. So it was just something I couldn't really get my head around. Anyway, so this was a 10 p.m. call and it was, oh, you can see it in the morning. And we asked for some photos and I said, this will not be seen in the morning. We need to swab that right now. So you guys have viral and bacterial swabs in the hospital. This is something you can do yourself. If you think something's infected, that's all we do is we swab it. If something, these are full of fluid. So what you would do in this case, if you want to see if it's zoster or HSV, and they're different viral swabs. One is, or they're 2 different orders, HSV or VZV, is if you poke it, like just clean it with alcohol, poke it with a little needle. You can stick the Q-tip in and you want to swab the roof of a lesion if you can. This would be just florid with virus. So this one, it wouldn't matter as much where you're taking it from. but basically as long as there is fluid there, you can send it. PCR takes a while to get back, which is why, like up to 5 days, which is why I usually, if I have a high suspicion, I just want them to be treated. I'm not waiting for a PCR. I knew this was zoster without any information, and we just said start it empirically, no question. So this was her after like 10 days. So she was crusted over at this point. So then you can switch to oral and talk about discharge. And this was her 3 months later. So just to show you how really terrible zoster can be, part of her problem obviously was that she doesn't have an immune system, and that's a big issue. Okay. And then what, I don't know if you can tell, but there is a lot of crusting still on her scalp. Yep.
So we had a patient like this. So like, you know, like 95% of the lesions were crusted. Like that one that was saying that, oh yeah, you get switch to oral once it's fully crusted. Like how strict is that all lesions have to be crusted before you take out the airborne precautions and switch to oral?
I am very, very strict about that. And the reason is you don't know who in the environment has been vaccinated to varicella. You don't know who's pregnant. You don't know who's had chickenpox earlier in life. I think to me that like potentially you're destroying a baby, potentially. I mean, obviously that's a very dramatic case, but that's kind of what you're saying, right? Because you can't ask a nurse, hey, have you had chickenpox or are you pregnant? You can't do that. So to me, I'm always going to err on the side of safety with that because I just don't think it's worth it. But very good question. So this woman had pockets of Pseudomonas all over her scalp where she was healing, and I could not clear her with orals, and she ended up having to have IV therapy. And I don't know if she's still alive. I actually haven't checked on her in a couple months, but just a really sad case, and to show you just how catastrophic this disease can be. So also just based on dermatomes, we know even from the first picture, this is likely disseminated. The second I knew that so this is at least 2 dermatomes, right? So this is 2 areas being affected here. She also had lesions on her chest that our residents saw. So immediately that's disseminated to me, especially if she's immunocompromised. I'm going to immediately put her on IV therapy because this can just blow up, and it's a terrible disease if it's not under control in immunosuppressed patients. PG is a tricky one, pyoderma gangrenosum. It is that wound that's not healing, or a surgical wound that is expanding. I debride nothing, almost nothing in my clinic. I am a very anti-debrider because I've seen this be debrided. I've seen so many things be debrided incorrectly that it's really like scarred me for life. And this is a patient who had multiple surgical flaps. She had a bad infection, and then they did, I don't even know what they did, honestly, to create this back that we're seeing here. And she was in such incredible pain. She was on opiates. They were still debriding her. So that like top really red, all of that's really red and open and active. And all we did, this was just 3 months of all I did was just little topical tricks. And then we injected with steroid around the edge. That was it. She was then off her opiates, so much better. It took her 7 months to get a derm referral. And it was like, oh my gosh, this poor woman, right? We could have helped her. So if in your outpatient or inpatient setting, there's a wound that's not healing, and it's not, you've swabbed it, it's not infected, nothing's growing, it doesn't smell funny, that's not what's going on, just keep pyoderma gangrenosum in the back of your head and give us a call, because it's the delay in the diagnosis that is almost always the biggest problem for patients, is that they're just sitting there and it's just, we're not clearing it. And they almost always are going to need systemic therapy of steroids, which is why it's tough, because usually they've just had a surgery or we're worried about infection, and there's no biopsy that can prove this. Another really tough part of pyoderma gangrenosum. Infections, inflammation. In this case, it looks exactly the same. So it's just a really tough disease, but you can make people feel better quickly, which is my point there. This was a case that we got wrong. Not entirely my fault, but this was a patient who had reported SJS-TEN. We were not consulted for, I think, a week that he had been here. And this ended up being bullous pemphigoid. The problem was he had been debrided, and I did not know that. And so when things are debrided, we lose a lot of our clues. And so this was an example of, because of the debridement, I thought his disease was sloughing, but actually it wasn't. And when we saw him, there wasn't a Nikolsky sign. Pemphigus can have a Nikolsky sign. Usually bullous pemphigoid does not. The chronicity was different. And then you can see he's repigmenting. So you can see like some of those areas that are darker. In the initial photos, I thought it was just superficial skin that was sloughing, but it's actually him repigmenting, showing us this is a really chronic disease. It takes like a good week or two to repigment. And it's rare to have ongoing SJS. We usually see that in dialysis patients who are just not clearing the med. Contrast in particular tends to linger really badly. But it was just these little clues of, oh, that's like, wait, he's repigmenting, that helped us understand what was going on with this guy. And just with steroids, he got better very, very quickly, which was great. This is not cellulitis. This is point 2 to please take home from this lecture. Lower extremity erythema is not always cellulitis. There is an amazing paper that came out that said that of diagnoses of cellulitis, if a dermatologist is involved, 80% of the time the diagnosis is changed. I'm not saying anyone is doing anything wrong. I'm just saying, remember that it's not always cellulitis. If your patient has, especially both legs, like perfectly symmetric like that, that doesn't even make sense. How would that even happen? This is lipodermatosclerosis, which is insanely common. If you walk around the VA and actually look at people's lower legs, like 80% of people have this, especially obese women. That's the population that has it the most. So basically, it's a vein disease that has gone wrong. So as your veins dilate, as that, they got to fight gravity. It's a long journey. It's tough. Your veins dilate and blood leaks out. Blood isn't supposed to be in your skin. That's very inflammatory. And so you start getting the inflammation. When you start to see this redness and the firmness start happen, that induration of the skin, that means it's now going into the fat. And now it's lipodermatosclerosis, and that's actually a paniculitis or an inflammation of the fat. It's so common, it's so undertreated, and it can be such a nightmare for patients who aren't getting treatment and they just keep getting antibiotics over and over when all they need is topical steroids and compression. And this will literally go away if they're compliant with that, which is amazing. So just keep that in mind. Sometimes it is cellulitis, don't get me wrong, but a lot of times it's not.
Is lipodermatosclerosis, is that painful?
It can be. Mm-hmm. It's very tender if you touch it usually. And what you're seeing, like this one is probably a decent example. It's pre-ulcer. The next step to this is at ulcers, because you can see all that inflammation that's in the fat. We're cutting off blood. It'll start to no longer have a good vascular supply. And that's when you're going to have ulcers. And those are very, very hard to treat, especially if the etiology is not really identified and treated. So this is that inverted champagne bottle that is this. It's not really this good, I'd say, in real life. This is from a textbook, but it's, oh yeah, I was like, so it's like supposed to be like that. Okay. But the leg, yeah, okay. It's inverted, but the patient's backwards, so it's not inverted. Okay. But that really sharp demarcation is pretty classic for this. Now, people with lipodermatosclerosis can also get cellulitis, especially if they have an ulcer and that gets super infected. So you can have multiple things going on. But again, it's just going to keep happening unless the other part is addressed. And again, the treatment is topical steroids and compression. This was a consult for cellulitis. They were trying to admit him. I said, please don't. And we just did topical steroids and compression, and that is completely healed. Yeah. Yes. In my maybe that's my opinion, but yes, I think so. That's a good question. The question was, is that on a spectrum with stasis dermatitis? And I feel yes. I'm sure someone would disagree with that, but I think yes. Okay, point 3 to take home. If you care about me at all, and I don't know why you would, we just met, but if you care about me at all, please don't on yourself or patients or anyone you love use Neosporin ever again. Just throw it away. Get rid of it. There were great studies. This was 10 years ago this study happened and people are still not reacting to it. Neosporin has the same antimicrobial properties as Vaseline. It's the same. The problem is that the ingredients of Neosporin that make it Neosporin and not Vaseline are one of the most common things you can be allergic to. So this is a patient who is, so bacitracin is in the same category. Just stop it. Just stop all of it. Bactroban, mupirocin is different. That's different. That's okay. Get rid of the bacitracin, get rid of the Neosporin. Never, never, never. This is a young girl who was hospitalized. She's putting bacitracin on a motorcycle wound on her leg. The motorcycle wound was like very small. It's under that little piece of gauze. This contact derm took over her entire body from the bacitracin. We had to hospitalize her because I couldn't rule out an eczema herpeticum. She had a history of eczema and this was so crusted and oozy. I was like, I gotta give this acyclovir. I'm really worried about it. She finally remembers, oh yeah, it's bacitracin I'm putting in there. I said, oh my God, stop the acyclovir. You're just raging allergic to bacitracin. So, oh my gosh, right? Like how many things can we prevent in my world if we just stop the Neosporin? I can't even tell you. So stop the Neosporin. It should be pulled from the market. It's amazing. They must have lobbyists. I don't know, but it should be pulled. See, never. Okay. Okay, so questions I've been asked that are common that come up. So if you are somebody who has keloids or you have a patient who has keloids and they're going to the OR, what can you do to prevent a keloid? Absolutely nothing. There's nothing to do. You can set them up with an appointment with us for like 3 weeks after the surgery, and we can see if steroid injections or topical therapy can be helpful, but actually during your procedure, not much. One of our residents, I had to do a skin cancer surgery on and he keloided, and oh my God, I did everything to not give him a keloid and he got a keloid. I mean, there's nothing you could do. And we injected him, we lasered him, everything. The keloid's gonna win. The keloids will just win. So just remember to tell your patient that. That's a really common like OB question too, but there's nothing to do. Usually keloids happen like here up, usually not here down, but not always. Which patients, this is more of an outpatient question, but who needs an annual mole exam? There's absolutely no guidance, right? The USPSTF doesn't tell us who needs a mole exam. I don't know. My general rule of thumb is any personal or family history of skin cancer. And by family, I really mean melanoma. My dad had a basal cell that doesn't actually affect your risk at all. The only ones that are more of genetic are going to be melanoma. So a family history of melanoma, a personal skin cancer history, just horribly sun damaged skin. They should probably get seen. And just like tons of weird moles. If they take their shirt off and you're like, oh God, you should probably send them, right? That's probably a good idea. The patient has a mild, it's like, mild, it's a little bit ishy. Can I try a topical steroid? Yeah, totally. Go for it. Feel comfortable with that. That's an outpatient thing you guys are going to have all the time. Start inpatient, like start now getting comfortable with some topical steroids. Clobetasol, so there are 7 classes of steroid strength. Hydrocortisone is like baby. Even the prescription 2.5. Very few things are gonna go away with a 2.5% hydrocortisone. Get comfortable with like that middle of the road triamcinolone. Go for it. See what happens. When we say your skin can get thin with steroids, we're talking months of inappropriate use. I have patients slathering their arm with clobetasol because they have psoriasis there. That's appropriate. We're not going to thin their skin. Their skin needs the steroid. It's when they're slathering their arm when it's fine for 3 months with the strongest steroid, yeah, you're going to thin their skin, but that's inappropriate use. So telling a patient use it twice a day until clear is actually really, really safe, especially if you have a follow-up in a month or two. Don't be stressed about that. You'll be amazed at what just a couple days of topical steroids can do and will save you and your patients a lot of trouble. So just get comfortable with it. Don't be afraid of it. I think a lot of, just because it's kind of foreign and unknown, a lot of people are scared of topical steroids. And I just think it is better for you as a physician and provider and to provide care, like better access for your patient to be able to be a bit more comfortable with those things. The patient has had a rash on the arm for 6 months. Can you come see her today? My issue with this is that when somebody has a chronic condition in the hospital, One, if they have if they have psoriasis and they have home meds, just restart their home meds. That's all I'm going to do. If they like already use triamcinolone at home, just restart the triamcinolone. Like that's all I'm going to do. So you can save the consult. But the problem is that pretty much everything I do needs follow-up. And it's one of those, okay, like, are they going to follow up? Are they going to see us? Are they already established with somebody? So just like keep those things in mind of, are we really going to be helpful? If they're just like picking at their skin and they've seen 20 dermatologists, like, you know, we're probably not going to fix them in a day. And really that's usually the time, like 1 to 2 days is the time frame we have to fix somebody in the hospital. So think about, is this something that can be fixed quickly? When in doubt, of course, call us, but just like something to keep in mind, I think. Yeah, start their home meds. That's all I'm going to do, literally. If they are already on something, just restart it. That's fine. Oh, so we get a lot of consults for cancers, skin cancers in the hospital. The problem is we can't treat them in the hospital. So skin cancers are generally an outpatient treatment. If it's anywhere on the head or neck, it's going to require Mohs surgery. That's a specialized form of skin cancer surgery that can only be done outpatient, period. You need a Mohs lab that only exists at our Oak Brook Terrace location. So I can do a biopsy and tell you it's cancer. I can look at it and tell you it's cancer most of the time, but I can't treat it. So sometimes the biopsy is like, okay, yeah, we got them a diagnosis, but it doesn't get us to the next step. So if they live in Florida and they're just here acutely, like we're not really helping them. We're actually just creating a new wound sometimes that can then get infected during their stay. So just another thing to keep in mind. If it's something that doesn't need Mohs and you want it cut out, we do not have OR privileges. So that is something that can't be done bedside. We just don't have like the tools that we would need. I think bedside, that would just be a hot mess. So plastics or ENT, I'd probably go plastics for most things on the body. They can do excisions though for an inpatient if it's something really big or you're worried about it, just so that you know, like kind of a who does what thing. Okay, and I think that's just your thing. Any questions?
Where's the best place to get VZV and HSV swabs in the hospital?
I don't know. It's a great question.
Where do you guys usually get them?
We ask a woman named Jackie Folk and she gets them for us, or we take them from clinic and steal them.
Sounds good.
Whether it's right or wrong, I don't know. That's a good question. But yeah, just like, you know, you're already there, right? You're going to get it faster. So also we're not in-house, in case, I think you guys all know that. But when a resident is on consult, they're actually in clinic all day and then come like after clinic. So the last question was sort of, oh, this patient is like, we're waiting on discharge for you. And it's like, right. But unfortunately, the way that our system works, we don't have dedicated faculty or resident time to do that. So just be patient with us. We're really trying our best and we're coming after our full day of clinic. So we're really doing our best. Okay, great. Well, thanks, guys.
Thank you.
Thank you. Oh, there's I'm sorry. Okay, so on an abrasion, instead of Neosporin or bacitracin, you use Vaseline. It's amazing. For real, that's all you need to do. The repigmenting, would that not happen in SJST? Yeah, no, it would. It would just be like it's not as acute. So this guy that was like that picture, it was like, oh, all of a sudden his skin is falling off. Well, actually it had been going on for a while, which pointed to a more chronic disease like bullous pemphigoid. So it does happen, but it's a later finding, like several weeks after SJS is after it starts, if that answers your question. Okay. Thanks, everyone. My pleasure. Yes. All your things. Yeah.
So like speaks to